Today, we're going to be talking about AI and breast imaging. And we have with us today someone that I'm very excited. I've been hoping to have Anne on this webinar series for a while. Anne Martel is a professor in medical biophysics at the University of Toronto and a senior scientist at Sunnybrook Research Institute, where she holds the Torrey Family Chair in Oncology. She is also faculty affiliate of the Vector Institute in Toronto and the CSO of Pathcore, a digital pathology software company that she co-founded in 2006. Dr. Martel is a fellow of the MICCAI Society and a senior member of SPIE and currently serves as a senior editor of the Journal of Medical Imaging Analysis. Her research program is focused on medical image and digital pathology analysis, particularly on applications on machine learning and artificial intelligence for detection, diagnoses, and prediction and prognosis. So we have in store a really good session. I'll encourage you, as always, please submit any questions you have in the chat, and then we'll try to get to them at the end. And one last little plug in case we don't have time. MIIT 2005 is coming April 25th, so it's just around the corner. We've got a number of great talks related to AI and things like that. So if you're interested in this, I think you might very much be interested in attending MIIT. And so with all that said, I'm going to stop sharing and I will hand it over to you, Anne.
Great, thanks a lot, Jason. I'm very happy to finally get a chance to present here. I'm just going to set myself up so you can see my screen okay?
Correct, yeah, perfect.
Okay, so I'll start with my usual conflict of interest. I'm going to reset my timer so I know how much I'm talking. I'm going to try and make sure I leave enough time for some questions at the end. So I thought I'd start off with an overview of what I do. So I run a research lab at Sunnybrook. So I'm embedded within the hospital research environment. And my main research interest is in AI for personalized and precision medicine. So the idea is that we take heterogeneous patient population, we can collect multiple modalities of data, so we can do pathology, get the clinical notes, imaging, and if possible, genomics. And then because people, clinicians collect all this data routinely, but we tend not to be able to, as human beings, be able to integrate all of that information together in an efficient way. So that's where AI and machine learning comes in. It allows you to take in these huge data streams and kind of boil them down, use AI to try and extract some meaningful information, some actionable items from that data. Once you've done that, you can start to try and create personalized treatment plans. If you know who's got an aggressive disease, you can maybe escalate the treatment. If you know who's going to have a more sort of benign indolent disease, you can try and do things like active surveillance and so on. So you can try and tailor the patient treatment to the kind of disease that they actually have as an individual, as assessed by all these data streams here. One thing I don't do very much, but sometimes certainly an interest at Sunnybrook Research Institute with focused ultrasound and radiotherapy is deliver targeted therapy. There's a big use for AI in that area, but I'm not going to cover that. And then another important area is once you've given the treatment, how do you evaluate it? And this comes down more to sort of numerical analysis of data. So, you know, quantify residual tumor burden, RECIST criteria, and all that kind of sort of thing. So today I'm going to actually talk about two areas. I'm going to very briefly touch on some work in radiology. So when I first came to Canada in 2003, I started working with Don Pluis on breast MRI. So I'll start talking about breast MRI a little bit. And then I'll move on to anatomic pathology, which is an area I've been digging into for probably about 15 years now. So I'll go on to anatomic pathology afterwards. So the MRI data, the MRI breast imaging, I first became interested in when I realized that when you go for an MRI exam, we do screening in Ontario with MRI for high-risk patients, women with BRCA1, BRCA2 mutations, and so on. And in a single MRI exam, you can have over 1,500 images. It's probably even more now. So by the time you've done a T1 weighted sequence with contrast, the T2, done some different views and so on, comes up with an enormous number of images. And the idea originally I had was computer-aided diagnosis to help the radiologist navigate this image. And this kind of built onto the standard machine learning paradigm. This got rebranded from computer-aided detection to radiomics at some point, but it's basically the same idea. You take your images, you find the lesions you're interested in. So these are all different lesions from breast MRI scans. And then you do something like extract some features that you're interested in, and usually a radiologist would help you decide what features are important. So you can do things like, you know, how round are they? What's the signal intensity? How big are they? And in MRI, we can also look at dynamic features. So how quickly does the contrast agent go in and out of the tissue? So we can get a whole bunch of information from there. We can collect information from cancer patients and lesions that have been diagnosed as benign. And these are all pathology validated ground truth labels. And then you take all of this information here and then you feed them into some machine learning classification model. So we started off this work. Jacob Levman was my first graduate student. He was doing support vector machines. And then we moved on to random forest and the like, Christina Gagego and we were looking at random forests as well. So we managed to do quite successfully on this. We managed at the end of the time we were looking at CAD for MRI. Hongbo was a master student and he kind of helped sort of front end the integration of this. So he used actually a neural network, but it wasn't a convolutional neural network. It was an old school, fully connected neural network to try and detect candidate lesions. So we had to go from a whole input image volume, find some candidate lesions, and then we used a random forest to decide which of these candidate lesions were likely to be biopsied or not. So are they biopsiable lesions? And then from the lesions that were biopsied, then we try and see what the diagnosis was. And we had quite a big test set. We were working with the radiologists here at Sunnybrook. And we actually got some quite respectable numbers for detection. So the first part of this was to detect these lesions here. And you can see we had about 3.8 false positives per breast. But when we went down to diagnosis, we sort of got down to less than 1 false positive per breast, and quite reasonable performance. So had we ever rolled this out, we would have probably, we think we'd have been able to, with reasonably high specificity, so not missing any lesions particularly, we would be able to reduce the number of negative biopsy. So a woman comes in for screening, the radiologist makes an assumption as to whether they need to go for biopsy or not. Over 2/3 of women who go for biopsy have a negative biopsy. So the aim of this project was to try and reduce that number of negative biopsies by increasing the likelihood that a woman had a malignant lesion before we actually biopsied the tissue. So this was all great, the numbers looked good. We actually worked, had a software developer, Yingyi Liu. We worked to actually embed this in the clear canvas viewer. Some of you may be familiar or remember the old clear canvas viewer, which was developed here in Ontario. So we actually managed to kind of create our heat maps and a lesion probability, stick them into a DICOM object, stick them into a viewer, and it all looked pretty good. But the problem was that the lesion segmentations weren't always ideal. I mean, this is a fairly diffuse area. This was actually a correct call, but it didn't look particularly pretty. But the real problem with this research project was, so this was about 2016, this was done. I couldn't get anyone interested in taking it further, and to take something from the academic research community. So this was tested in the bench in kind of a lab environment. I forgot what technology readiness level that is, but it's low. We needed some input from a company really to take it further. And about this time, Clear Canvas then became part of Synaptive. So they weren't interested in collaborating, particularly on breast imaging. I couldn't get GE or anyone else to look at it because everyone said, well, nobody does MRI for breast. So this is one of those sad things where we kind of dropped that research area. And now actually there's quite strong interest in breast CAD. So I am actually thinking about retooling. So anyway, we kind of stopped developing the CAD algorithm. We did move into a little bit of predicting risk of breast cancer using MRI. So this is taking screening patients who come for screening MRI. And we were trying to decide on the first MRI, how likely were they to be at risk for breast cancer in the future? And the idea here was that we could maybe try and stratify patients in the screening program a bit better. So Greg Cooley was another graduate student. He worked on trying to assess the risk using 2 different parameters. One is density. So we know that dense breasts, actually women with dense breasts have a higher possibility of having cancer, and that's independent of whether it's detected or not. They actually have a higher risk. And also we know that the background parenchymal enhancement in dynamic contrast enhanced MRI is also associated with risk. So radiologists already have a way of trying to categorize these. They have a schema called BIRADS. So they would give images a score of fatty, scattered, heterogeneous, or dense. And they could also score the BPE. But these were very unreliable measures, high inter-observer variability, and so forth. So what Gray did was try to generate some AI models. He developed a segmentation model to get the breast and the fibroglandular tissue. And then once we've got those, we can then take the background parenchymal enhancement, feed that through another regression model, and develop a risk prediction model. So that work is kind of just, we finished the project now. We need to decide whether to take that on further. But this was all the radiology, the work I've done so far. I am now moving back into looking at things like liver metastases and things like that. But I got very distracted about the time when we were having difficulty getting funding for radiology by the advent of new digital pathology images. Logo's got cut off here. So I said that there's over 1,500 images in an MRI scan, but in a single whole slide image, which is what you're looking at here, the amount of pixel data in there is equivalent to about 50,000 MRI slices. So what you're seeing here is this is the whole slide image. This box tells you what you're looking at in the detailed view. And you can you can zoom all the way into 40 times magnification, 400 times optical magnification here. So you can see all the way in to see the cells. This is a normal breast duct here. So you can see the cell nuclei, the stromal tissue, the fat, and so on. And then when we zoom out, you can see the kind of distribution of ducts throughout the breast tissue and so on. So these images have a huge amount of information in them, and I got kind of excited by that. So one of the first things we did actually was it was Martin Yappy's lab who were looking into this to start with, and they had these beautiful whole slide images, but there wasn't any really good software at that time available for researchers. So they were particularly interested in correlating these whole slide images, and they had whole mount images as well. They wanted to look at that, correlate it with mammography and so on. So they turned to me and said, well, have we got any good way of viewing these huge images? And the Aperia viewer was around, but it wasn't very functional for sort of anything other than just looking at different zooms. So at that time, I managed to get some funding from the OICR. I hired in Danush Hossainzadeh, who is now the CEO of Pathcore, and he built this viewer called the Sedim viewer. And what this does is it lets you take in a whole slide image, and it lets you do things like annotations. So you can see some annotations here on there. You can make measurements and so on. You can actually show images side by side. You can do overlays, and you can actually plug in C programs as well. So at one point we had some NIH funding to do some extra work. So this kind of cemented my interest in this area. And so then once we've figured that out, we start to think, well, okay, what can we do with these images in terms of the machine learning that I was interested in? And it turns out there's many different applications of AI in digital pathology. So you can do things like use models to do quality control automatically. So can you find out of focus areas? Can you find areas of pen marking and so on? A very big area is in detection. So these images are huge, like I say. So can we help the pathologist do things like find mitotic cells or find regions of cancer and so on? Once you've found these regions, or once you've done an IHC stain or something, can you count the number of cells? Pathologists hate counting cells, high inter-observer variability. It's the sort of thing that a computer algorithm can do much more effectively and more quickly. You can also train classification algorithms. Classification on its own isn't terribly useful necessarily, but you often need it for segmentation. So this is an example here of a DCIS image. And what we've done is superimposed a heat map to show where the DCIS cancer is sitting, or pre-cancer is sitting. And then the other area that I'm particularly interested in is prediction. So can you take these whole slide digital pathology images and make a prediction about the outcome of the patient? So are they going to respond to a particular therapy? Are they going to have a cancer recurrence in 5 years' time, and so on? The really exciting thing about prediction actually is that you can try and do this end to end. So you can try and make no assumptions about the data, and there's a potential for discovering new biomarkers and things like that. So huge area of research, lots and lots of things to do. So when we first started, this was back in the day. So we basically took the toolkits that we'd learned how to use when we were doing radiology, or the radiomics, the sort of taking features that we know that the pathologists, radiologists use, and try and interpret that into a computer vision workflow. So the first thing, one of the first projects we did, Mohammed Bakari was one of my first digital pathology PhD students. The tasks we decided to do, first of all, under guidance with Sharon Nofek-Moses, the breast pathologist we've been working with for many years now. She said, well, one thing we want to do is quantify how much cancer is left after the patient's been given neoadjuvant chemotherapy. So a patient with breast cancer, sometimes instead of going straight to surgery, they'll actually have chemotherapy before surgery. And the idea is that shrinks the tumor, it's been shown to improve outcome and so on. So her question was, can we take an image that's acquired after surgery? So the patient has the chemotherapy, they go to surgery, we get a big lump of tissue removed, and this is one of those sections from a resection specimen. And then the task of the pathologist is to quantify how much tumor is left in there. So we generated some training data. Sareen Salama was a research fellow, pathology fellow. So she dropped down all these boxes on these slides, and then basically quantified what percentage of cells were cancer in each patch. So you can see some of the patches are normal. This is a normal piece of breast tissue here. And this is a piece of breast tissue with cancer. So these are just normal epithelial cells in here, and these areas here are cancer. So what Mohammed did was, like I say, straight up pathomics approach. So the first thing to do was to find all the cancer cells and segment them. So unfortunately, he used red as the annotation marker here. So it's a bit difficult to see. You can see each cell has been outlined in red on the two slides. And then you generate things like the intensity, the size, the circularity. So a bank of like 300 or so features from each cell, and feed them into a support vector machine classifier. And that lets you then classify each individual cell as to whether it's a lymphocyte, a benign cell, or a cancer cell. So he did this. You can see these nice heat maps here. So this is the area of normal tissue. Like I say, mostly correctly classified. There's a few little lymphocytes in here, mostly normal epithelial cells. This area here is cancer, correctly classified, and these are the immune cells, the lymphocytes here in green. So he did a very nice job, and we could actually run that over whole slide images and get these heat maps here. Now, the problem is this is an old school approach. I mean, he did write it in MATLAB, which is also another reason why it was slow. But this could take like 2 days to process a whole slide, because he had to go patch by patch, individually segment all of those nuclei, extract the features, and run it through. So it was really slow. And what happened then was technology changed completely. So in about 2012, I think it was it 14? I forget exactly which year. The ImageNet competition, which is a large computer vision competition, is run every year. And what they do is they take over 1 million images, 1,000 different labels, and the task is to classify each image according to a label. And up until about 2012, this technique was run by a load of computer vision techniques, not unlike what I've just shown you. And then in 2012, I think it was, Jeff Hinton and 2 of his graduate students entered the competition using what's called a convolutional neural network. So many of you will be familiar with this, but I'll just go through it. So a convolutional neural network, what you do is you take in your input image, and you take a label. And instead of trying to predetermine what features you want to look at, you don't. You just train a network completely end to end. So what you do is you take your image and you're training this little convolutional filter here. So instead of trying to train something for every pixel in the image, you just take a little convolutional kernel of 3 by 3 or 5 by 5 or whatever the size is, and you try and learn the weights on this convolutional kernel, and that gives you one feature map here. And then you might have a stack of M feature maps. So your neural network basically learns the weights and biases for these little convolutional filters. Then it does some downsampling, and then it does it again on the next stack of features and does some downsampling. And eventually you go out and you flatten this, turn it into a one-dimensional vector and a fully connected neural network, and then you come up with a prediction. And the idea is that you feed in your image, and then you compare the output label with what you know the correct output label is. And then you basically do the backward pass where you change the weight. So this is back propagation, and you do it again. And you just keep running the images through, comparing the output with the input, correcting, and so on. So this means that you don't have to design any features. You can do pre-processing, but you don't really have to. And it basically fast forwards the development process. So this is the original handcrafted engineering feature pipeline that we had. It probably took Mohammed about a year in total to basically optimize each step in this pipeline and come out with a cellularity score. When Shazia Akbar, a postdoc, joined my department, she basically took the same data set and used this convolutional approach, and she'd basically reproduced his results and bettered them within about a month. And then we decided, right, okay, let's just see how good this can get. So we ran a challenge. And in this field for digital pathology, challenges are really important. I'll show some more examples later. So what we did in 2018 is we took the data that Shireen had annotated. So that was almost 100 whole slide images. Over 100 whole slide images should got a whole load of patches. So we released a training set from 37 patients. And then we held back a test set that we didn't show the competitors until the end of 18 patients. They basically had a couple of months to come up with an algorithm and then test it on our test set. And when we did this, we had 41 teams actually managed to submit entries to the competition, and 21 of those actually managed to better the performance of our other pipelines. And these teams, I have to emphasize, did not know anything about pathology. So the top two teams, I think one of the top two teams went and consulted with the pathologist at one point just to understand what a whole slide image was. The other guy was a graduate student in a computer vision lab who knew nothing about digital pathology. So this just shows you how convolutional neural networks and AI can really accelerate the process of doing automatic image processing. Now, these things, of course, weren't perfect. So Nick Pertic was from the FDA and some of the other authors here as well. So they analyzed the results of the challenge in detail with us. So they picked out some of the example images where everybody passed. So here, the P score here is the pathologist assessment, and A is the average of the 20 algorithms that we assessed. So you can see here the pathologist score is 0 because this is a piece of normal benign epithelium, and then most of the algorithms got that right. They agreed this looks like normal tissue. And this one here has a pathologist cellularity score of 90%, and again the algorithms are all pretty correct. They recognize these as cancer cells and managed to calculate the area pretty well accurately. But the errors were actually quite consistent. So this is one here where there's no cancer, but the normal cells are quite tightly packed, so it doesn't really look like a normal epithelium. So a lot of the competitors got that wrong. Average was 50% cellularity when it should be 0. This one here, most of the algorithms overestimated the amount of cancer cells, and you can see this is the area of cancer here. But all these cells out here are actually lymphocytes. So what probably happened is that people's algorithms weren't properly distinguishing between lymphocytes and cancer tissue. And then these two are examples of rarer histological subtypes. I'm not sure, I can't remember now whether either of them were represented in the testing set. I mean, in the training data set, but they were in the test data set. So mucinous cancer, inflammatory cancer, and so on, they have very, very different appearances in the cells. And that led to the algorithms all going. So this kind of undermines the fact that when you do train an AI algorithm for anything, but particularly in pathology, you need to have a lot of data. You need to be able to cover all the edge cases, that the algorithm has to see all the different kinds of images and so on and so forth. So for that reason, digital pathology really heavily depends on these challenges. And I've put up some of the challenges here that have happened in MICAI, which is my main society over the years. And Chameleon, actually, the first Chameleon challenge happened in 2016. And this was a kind of revolutionary challenge that kickstarted certainly the industrial interest in digital pathology. So people like Google got really excited about it when the Chameleon dataset came out. This was a dataset of whole slide images of people's lymph nodes, breast cancer patients, lymph node resections, and the task was to find tiny metastases. And I'll actually show you some of this data later on as well in one of my slides. So the key thing about this was they addressed a real clinical problem. So there was actually possibility of a real commercial product at the end of it. Pathologists wanted something to find micrometastases in lymph nodes. They had really good annotations on the whole slide. So instead of taking small patches, they did the whole slide imaging. So this was a really quite an impactful challenge. And then things like mononucleg, this is like millions and millions of cells that have been labeled of different types. My dog looked at different scanners. So this is the same tissue from different scanners. Some looked at image registration. This is our challenge here. I'll show you tiger in a minute. This colon, this is prostate, and so on. So every year at MICAI, there's at least 2 or 3 different challenges that produce high quality annotated data sets with a clinically relevant problem for people to go and tackle. And then attached to this is also the fact that you can actually now download models. So you don't have to start from scratch. You don't have to train your neural network from nothing. You can go on to Hugging Face or people's GitHub repositories. And this is an example here of a model called HoverNet. It's a UNet-like model. But the key thing about this model was it was designed for cell segmentation. So it does something quite neat with taking these horizontal and vertical maps. So it solves the touching nucleus problem, basically. But the reason why it's quite cool is because you can download this this model, put in your own data, fine-tune it, and come out with something quite quickly that allows you to do cell segmentation, for example. So the rate of progress in this field has accelerated massively because of large data sets that are available and also many models that are pre-trained. So as an example, this is a challenge from a few years ago now called Tiger. And the idea was to take the scoring of tumor-infiltrating lymphocytes in breast cancer. So there's a whole group of pathologists who believe that this TIL score is related to outcomes. So if you can quantify how many infiltrating lymphocytes there are in the tumor stroma area, you can get a pretty good assessment of how aggressive a cancer is. So what the organizers of this challenge did was they took a whole load of whole slide images and annotated the tumor. So we've got some nice annotations around a whole tumor. And then they went into some patches on the images and gave us very detailed annotations of places that are invasive tumor, tumor-associated stroma. And there are also some cell annotations of tumor-infiltrating lymphocytes. So I had a new graduate student in my lab at the time. Vishwesh had just started his career as a graduate student in digital pathology. So within a couple of months, this was the first thing he ever did. He managed to go for whole slide images. He managed to train a tumor classification algorithm. He managed to find the tumor-associated stroma, generate a TIL density map, and actually enter this competition with a model that actually does predict outcomes. So he did quite well in this, and the paper hopefully will be released soon for the challenge. So all great. Given a labeled data set and a good problem, we can make really fast progress. But the problem is we often don't have labeled data sets of the kind that we need. So a traditional approach in computer vision is, say you want to train an algorithm to tell the difference between 2 different makes of cars. So you can get a really small detailed annotated data set of cars that you're interested in. And what you can do then is take this ImageNet. So I mentioned before the ImageNet competition. It's millions of images, thousands of labels. People have trained all sorts of different models. You can get CNNs, ResNets, transformer models, whatever. All these pre-trained models that have been trained on this huge data set. And the idea is that when you train a model on a data set, you may not be interested in the final layers where it kind of classifies what you're actually looking at. And here we've got car, truck, bicycle. But the intuition is that these intermediate layers, what they're doing is they're learning weights that are important for vision problems. So we know that these early weights, these convolutional filters we learn here are related to edges, for example. So you can basically like an edge detector in here. And then as you go through here, these convolutional kernels start to integrate different features. So you get lines instead of edges. If you were doing faces, for example, you would go from edges to eyes and noses to whole faces to the final classification. So the idea is that you take the weights on these early layers and you use that to kickstart your new problem. So then you need fewer data sets to actually train your model at the end of it. So if we were interested in cancer or benign, the idea is we could take a pre-trained ImageNet and it would work on this data here. Now, the problem is, of course, is that natural images look nothing like pathology images, very, very different domains. But we don't have huge labeled pathology data sets. So this is where self-supervised learning comes in. So what do we do if we want to pre-train a neural network with millions of images, but we don't have millions of high-quality labels? And this is the answer to that problem. So what you do is something called self-supervision. So you take an unlabeled data set, a large unlabeled data set, and you come up with what's called a pretext task. And this panel shows you some examples, pretext tasks here. So in this one here, you tile the image, you feed in these 9 separate images into the neural network. And the task the neural network has is to reassemble these into the correct order. So you don't need to have any human labels or anything like that. You're just trying to perform a task where you know the answer to the task. And another very powerful model that's often used in microscopy is called infilling or inpainting. So you take an image, you artificially remove some of the image, and then the neural network has to try and predict what's in that image. So what you do is you feed in your millions of unlabeled images into these pretext tasks, train your convolutional neural network, and then you do what's called knowledge transfer. So you take that neural network, you push it down to your small labeled data set, and then you fine tune this convolutional network for your downstream task. So that's using pretext tasks, but there's another big kind of family of models called contrastive self-supervised learning. So here you're not even trying to perform a task necessarily, you're just trying to force the model to learn something about the image appearances. And the way it does this is by contrastive learning. So if you take, say, for example, an image here, this is your key image, and you take a bunch of different images that aren't this image. And all you have to do for this kind of thing is assume that in your batch, you're going to take one image as your probe image and the other image as the counterfactual. And what you do is you create copies of these images. So you change the appearance of this image in some way, and you can see you can change the color scale, you can flip it, rotate it, warp it, and so on and so forth. But what you want your convolutional neural network to do is understand this image is the same no matter what you do to it. So it shouldn't matter whether you flip one of these images upside down, you should still have the same representation in your neural network as you had before. So what you try and do is you train your neural network so that it's impervious to these augmentations. So what you try and do is this is all the same weights in the same neural network, but if you feed the augmented images in, they should come to something that's very, very close together in what's called latent space. And then for the other images, you do the same thing. And you want these other images, anything that's based off this should cluster together, but it should be far apart from this image here. Okay. So what one of my students did, Ozan, he was a graduate student in my lab at the time, and Tony was actually a summer student at the time. They crawled the internet, took 57 data sets for pre-training. We had over 4.5 million patches in the end. And they basically took any kind of pathology image that they can find. So these are from Kaggle, from MICI challenges, from the Cancer Imaging Archive, from the NIH, and so on. So some of these are cell images, there's different stains, different resolutions, and so on. And they actually trained a whole bunch of ResNets. And we made this ResNet available on the internet. I think it was only the ResNet 18 we made available to start with. We've now made all of the ResNets available. And people could download these and actually use that as their kickstart. So you could actually then start to get sensible downstream performance with much, much smaller data sets. And just as a kind of intuitive way of understanding what's going on, this is what happens when you feed the patches through this pre-trained neural network, and then you cluster the patches. So the idea is that you've fed them through a network, you've gone from a 512 or 256 by 256 patch, you've turned it into a latent vector with just 512 elements, and then you cluster those elements in 512 dimensional space using something simple like k-means. So that's what Ozan did. And then what you're looking at here is each group of 3 is 3 images from one of those clusters. So each of these is a separate cluster. So you can see here that the clustering is actually very accurate. So you can see these 3 images look quite similar. They're in a different cluster to these and so on. So this has got cover slips in it. This has got pen markings in it. We've got blood here, background here, fat here, and so on. So this means that when you try and train a downstream model, you're starting from a point that already understands quite a lot about what a digital pathology image looks like. And the other cool thing you can do is take one of these clusters. For example, we take this cluster here and then just map the images that have a good fit to that cluster in here, you can start to do some segmentation and so on. So this works really, really well. So this has been taken on and run with. So we did this work in 2020. That's when we released our network. It was trained using something called SimClear, and it was a ResNet. And it was relatively small. It only had about, well, smallest one had 11 million parameters, which is tiny by modern standards. And then in 2021, the term foundation model was coined. So this term didn't really exist when we did our work, but we basically trained a foundation model because we trained it on a broad range of data, which was somewhat relevant, but not curated. We used self-supervision at scale, and then this model, we showed that it could be fine-tuned for a wide range of downstream tasks. So since then, the field has exploded. So slightly slow start, a couple of new models happened. So Tencent trained a sort of hybrid CNN vision transformer. This was very effective. And then in 2024, we have Page AI, who work with more like ketamine data mostly, Microsoft, and then a very, very active group from Faisal Mahmood in Harvard, all released these gigantic foundation models. And in actual fact, this slide was prepared in September last year. Since then, there's another half dozen or so big foundation models being trained. And these have been, again, like a rocket booster to research in this area. And the reason why it's really important to have a really good foundation model isn't just because we don't have many labeled cases, but when we're doing digital pathology, we don't have very strong labels. So when you're doing a radiology task, you might be looking for, say, a tumor in a mammogram. So you have, in a mammogram, say, you might have one 2000 by 2000 pixel image, and you're trying to find an object in there. So your label for that image is still weak, but it's not super weak. You only have to look through that one image. In a whole slide image, we might have a label that says this patient has, somewhere in here, has a cancer. Or we might have a label that says this patient here is going to have a recurrence in 5 years. And we might have another patient that recurs in 3 years or so on. We don't actually know where in that image that information is contained. And I've already shown you that this image here is equivalent to tens of thousands of patches. So what we need these foundation models for is to take all of these patches in an image here. So you patch this image into the tens of thousands of patches, and we need to reduce the dimensionality somehow. So that's where this feature extractor comes in. So all these foundation models are used as feature extractors, and we extract from them patch features. And then we have to have a whole family of new AI models for doing attention-based mapping or attention scores and so on. There's many, many different ways of doing this. So then we have to take all of these patches and somehow decide which patches we're going to pay attention to. And then we put that into a smaller vector now, which represents a whole slide image. And now we can do our labeled mapping. So this is a very nice figure here from this paper, which shows one way of doing this for ovarian cancer subtype classification. So the better the foundation model, so really the success of all this is very heavily dependent on the success of this and capturing that domain in an efficient and compressed manner for these patch features. And then also, I'm not going to go into this in this talk here, but this attention mechanism is also very important. And actually, people have moved on from just having images now. So some groups have actually taken to scraping the internet from images which have captions. So Twitter was one place where people could scrape this. This was before it lost its mind and became X. So you could actually, at one point, you could get an API that allowed you to scrape the labels on Twitter, scrape the images, and you can train what's called a vision language foundation model then. And this is also being done in the radiology space as well. So the idea here is you take your text data, so some radiology report or just in a paper or something, someone's written some text about this thing here. You feed it through a large language model encoder, so it gives you an efficient text encoder here. And then you take your image encoder, so you take your images, feed it through one of these image foundation models, and you've got your image encoder here. And what you then try and do is it's like a contrastive learning type thing. You try and train a model. You adjust these encoders, so you fine-tune these encoders so that the encoders for the text images somewhat predict the image encoding and vice versa. So what you're trying to do is bring the image and the text descriptions close together in this latent space. Okay, so it's another contrastive method. And it turns out that adding the language information really helps in encoding. So this is sort of the next stage of foundation models is the vision language models. And then you get even bigger models. This is from Harvard, but I think Microsoft have also released one where you take the whole slide image and you try and encode the whole image. So these are foundation models based on whole slide images now. So this is something appropriately called Titan. It takes patch encoders. It uses a patch label encoding, and then it does some vision language model encoding as well, and it takes in the whole slide. So this is a really very, very powerful model. In our group, we're trying to do multimodal, multitask level encoding. So this is a paper that's actually being submitted to a conference at the moment. It's on archive. So what my students are trying to do is take the patch encoding, and they're trying to do it so that we can do some fine tuning. So instead of having to retrain these things from scratch, can we take existing foundation models, do some prompt tuning on them, use the text information and the genomics information and the pathology information and kind of mush it all together and use everything together. So this is very much sort of cutting edge work in progress. Okay, so that's kind of like a very fast romp through where we are. But I thought I'd go back to some kind of practical implementation of okay, so can we actually solve a real problem? We can see that we can do all these cool things on this test data, but what I really want to do now is try and solve something real. So I already seen the cellularity work. This is one of the first things we tried to tackle. And the reason why we tried to tackle it is because when I went to Sharon Novick-Moses, our breast pathologist, and said, right, what would be useful for you as a pathologist? What tasks should we try and solve? She said, well, assessing residual cancer burden on whole slide images is actually quite time consuming. It can take about an hour and a half to get a proper measurement of residual cancer burden for predictive purposes. And it seemed like a good thing for digital pathology. So it's made up of several different components. You have to assess cellularity. So is there any residual cancer cells available there? How far over the tissue bed does the active cancer still exist? How much is being killed by the chemotherapy? Sorry, to remind you, these are patients who've had chemotherapy before we've taken the tissue. So all the cells in these tissue samples here have been exposed to chemotherapy before it's been removed from the patient. So we've got these 4 different metrics: the extent, cellularity, whether it's invasive or not, and also the lymph node metastases, which I'll come back to in a minute. And once you've calculated these and put it through this index, you get something that works quite well as a predictive assay. So instead of doing Oncotype DX, which costs thousands, maybe we can train an assay just based on digital pathology. And this is data from Sharon where she showed that, any one case might have many, many different slides. So you don't just have one slide with lymph node metastases, you might have a whole tray of slides and then the tumor bed as well. So for a complicated case where you've got some residual cancer, it's complex, it's a whole mastectomy, 46 slides to go through, it takes an hour and a half to get this measurement done. So clearly, so clearly a good target for AI. So I mentioned before the Chameleon data set. So this was exactly the task that Chameleon set out to answer, was taking a lymph node section with some annotations of where the tumor was. Can we predict an AI? Can we use AI to predict where the tumor is? But Chameleon data was all treatment naive. So it was a big data set. They added to it in 2017. So you can see we've got 2 million training patches, 600,000 testing patches. But none of these patients in this data set had been exposed to chemotherapy. And Sharon tells us, well, no, this is going to be different. As soon as you add chemotherapy, it changes the tissue. So Dina Bethony was a fellow in the lab. So she actually went through and annotated another whole ton of patients. So almost 300 patients. And we're going to get some more data as well for some extra cases. So again, over almost 2 million patches for training, almost 1 million patches for testing. So this is what we've come up with. So Tony is a graduate student in my lab. What he decided to do was to do a 2-stage thing. So I've already explained that extracting information on a patch level is important, but you need to integrate the patch level information to get a slide level prediction. And lots of the work in detecting lymph node metastases is being on weekly labeled data, so you try and go end to end. But the problem is then is you don't get a very good heat map. So what you're looking at here is a digital pathology slide of lymph node metastases. The labels here were generated by Dina. So the red is the tumor in the node, and then this is what's called extranodal extensions. This is also cancer as well. And the heat map was generated by Tony. So what he did was he did a patch level classification algorithm trained on this data. And then what he did then was he trained a new attention network to combine the patch level predictions into a single slide prediction. And he's got really excellent performance, an AUC of 0.986. So if we set our decision threshold on the test data set so that we have 100% sensitivity, so we don't miss any cancers, we have a specificity of about 70% at the whole slide level. So really very nice results that he's got here, and this has been published in Laboratory Investigation recently. So this kind of digs into it a little bit more about why we had to change the training data. So this is the chameleon data here where it hasn't seen any neoadjuvant chemotherapy. And this area here in blue is the area that's been affected by it. So this is the residual tumor bed. So this area here used to all be tumor, and the tumor's kind of regressed a little bit. And then there's a load of kind of dead tissue and things from the chemotherapy in here. And what you see is that when you train the heat map on the chameleon data, you get lots and lots of noise out here. And that noise is very much reduced on the post-nat. So these green points here are small areas of micromets. And in actual fact, Dina didn't exhaustively annotate this slide. So at some point, we need to check whether these areas here are actually cancer as well. But this is a cleaner example to look at, and this is one we're really excited about. So this is a whole slide image here. This was actually a false negative prediction. So at the slide level, we said this was negative. But when you look at the heat map, so both of these methods actually said it was negative, both these data sets. But when you look at the heat map, you can see something really interesting. So on the chameleon data set, we've got tons and tons of clutter here. So the heat map shows positive areas all around here, which are just changes due to the chemotherapy. When we add the chemotherapy data to our training set, you can see that this removes all the clutter. But the cool thing is the one single patch that still has a high value. So there's one patch in here that comes out with a high positive predictive value for having cancer. When we actually reviewed this false negative, the pathologist was able to say, well, actually, this is cancer here. So we have found this tiny area of cancer. So although the slide level prediction wasn't affected by adding the neoadjuvant therapy, the patch level heat maps were totally affected by it. So what we're thinking about doing now is using that. So when we give we're going into a phase now, we're going to try and evaluate this on more clinically relevant data. And one of our thinkings is instead of just giving them a single value at the slide level, we'll give them the heat map. But we'll also take out like the top 5 patches from each heat map and show those to the pathologist. So even if we've got a negative slide level thing, they'll see these top patches and think, well, okay, actually that's cancer. So we found a micromet. Similarly here, here's another one, single tumor cell comes out top in the patches here. And this is a false positive. So again, if we show them the most likely to be cancer slides, the pathologist can very quickly say, well, actually, that's got it wrong. This is not cancer. This is something different. So we're really excited to try and do that. So this brings us to kind of an area of challenge in digital pathology. So there's all these AI algorithms out there. How do we present them to the pathologist? So we've done a little bit of work. This is on TP53 stained images. So one of my software developers, Lukash, he's developed a portal in Flask to try and show these images with the quantitative numbers. But we're also going to be looking at Pathcore Flow, which can upload the heat maps and so on, and try and use that for the pathologist. So we really need to spend some time in figuring out how we can take the results from the AI algorithms and present them to a pathologist in a way that's not going to interfere with their workflow. So this is not ideal because it's a separate portal. And we know from radiology that you can't have pathologists and radiologists have to switch from one application to the other. So that's an area we're going to try and have to work on. And we're also going to have to work on how to summarize the information and what level of information do they want. We're not going to remove the pathologist, but do we use the AI to triage the slides? Do we use the AI to point to areas to look at first and so on? And this application here would be, do we use the AI to score things and how do we score things? So just changing tack onto some of the software tools. So this is work by Lucas Sittert in my lab. So he's a software developer. He spent a lot of time creating this Python package called DP Lab Tools. And this is one of the reasons why my students can enter many of these competitions. And actually, we've entered quite a few now and come in the top 3. And the students spend like a month on the problem. And the reason why they can do this so quickly and effectively is partly because we've got a lot of experience in AI, but also partly because they don't have to waste time in developing code to handle these huge digital pathology images. These images are all in proprietary formats. So there are a couple of different reading libraries like OpenSlide and so on. So we can change the underlying library to any of these reading libraries, switch between OpenSlide and BigTIFF, for example. And then we've got functions for doing background removal, for example. We can take in annotations and create tiles. The students always have these weird things that they want, like we want to have tiling done within the annotation, but not outside, and all different shapes and so on. Very efficient ways of showing heat maps for troubleshooting and so on. We've got some nice inference classes in here. We can support multi-resolution. And Lucas has also done a lot of work on pool classes for parallel whole slide image processing. So we were able to actually work very effectively with the whole slide images. And this has all been released on PyPy as a package, and we've got to read the docs thing as well. So if you're trying to do any work on image processing, like I say, it's a very nice package. It's been written in a very Pythonic way, so you can inherit classes and things like that. And the other area I'm working on a lot now is to try and integrate image information with all the downstream medical data. So what we've got here is something called the OMOP Common Data Model. So this common data model here was developed to try and carry out observational research at scale, so multiple centers sharing all their data. And the idea is you take all the information from the electronic health record and you try and push it into this sort of common data model. And what we've been doing at Sunnybrook, I've been working with image management, Richard Mraz's team in information management. So they're taking information from all our different data sets. And at the moment, Sunnybrook has kind of like 20 different source systems. We're going to be moved into Cerner eventually, but we've got lots of different data sets at the moment, like CoPath and WinRex and so on. So Richard's team pulls that information in HL7 and into a FHIR database. So we have a FHIR repository. And then what we're doing then is we're de-identifying the data and moving it into this OMOP-based common data model. And this takes a little bit more time because everything in here has to have a specific code. So we have to take, say, the pathology information and put it into SNOMED coding and so on and so forth. But the nice thing is once you've got it, then you have the ability to link pathology information with radiology information, with drug information, and so on, all in this database here. And then we're also looking at integrating the radiology information. There's this group here as part of the Odyssey forum, and they've released this sort of white paper on how to integrate image information here. And the idea is you extract DICOM tags from the radiology data, create a new table, and then integrate it into this platform here. So this will be very exciting because it will let us try and do more multimodal information as well. And we're also working on the use of large language models to take the clinical notes and then pass that information again into a way that can be stored into this OMOP schema here. And hopefully at some point we have to share, the idea is this makes it easier to share between institutions. It doesn't take away all the problems because the coding may still differ between institutions, but there is a common standardized vocabulary at least. So at least you've got the same schema and you can then try and map the vocabulary terms specifically. So this is a very powerful way of sharing data in the future. So just to summarize for digital pathology in particular, so in pathology, we've got models that actually also applies to radiology to a large extent. So in research, we've got models that have been shown to work on a huge variety of applications. We can train new models efficiently. Foundation models are really a game changer in making things fast. But our kind of success criteria are disconnected to the clinic. So novelty is always the primary metric. So you'll want it to get published if you do something new rather than just show that the old things can work quite well. And grant funding, again, is often based on novelty. But in the clinic, we are finally getting a transition to digital workflow and pathology, and obviously radiology has been there for decades. The radiologists are very receptive to AI as a rule, and there are some commercialized algorithms, but the value proposition is still a bit unclear, and the cost and time for adoption into the clinic is high. And still safety and robustness are major factors. There's still a long way to go before we can bridge this gap between all the cool research stuff and the clinic. Hopefully that gap will start to close in the future. So finally, to finish off, I want to thank all my lab. So this is the lab members who've been specifically associated with breast imaging. Also, a big shout out to Sharon Nerfic-Moses, who's been working with me for many, many years now. Thank you, Luz, another breast pathologist we started to work with, and some of the fellows who've done a lot of the hard work. And then, of course, all the cool stuff in my lab is done by all these bright young people here. So thanks to them, and thanks to our funders as well. So thank you very much.
Thank you very much, Anne. Really appreciate you taking the time there and going through that with us. That is terrific information. We're at just a couple minutes, 12:58. Looking in the chat here, I don't see any questions that have come in other than some great comments about how good the presentation was. Yeah, maybe we'll just leave it at that. I maybe within the past 2 minutes, you mentioned ImageNet. I love asking anyone that's working in the ML AI space in Toronto, what if any influence that AlexNet had on you in 2012, being close to Toronto and all that. If you wanted to share some thoughts, if that had any impact at all.
Well, really, no. So it's interesting. For me, the impact was actually from a Swiss group. So Schmidt-Huber is kind of like the Domadian of AI in medical imaging. So he's had a group doing something very similar to the CNN network around about the same time as all the work was being done by Hinton in his lab. And at the same time as Hinton was winning ImageNet, Schmidt-Huber's lab took part in a competition to find mitotic cells in patches from microscopy images, and they won that competition with their convolutional neural network kind of approach. So that I saw, and then they did it again at a Mikai challenge in about 2016 or something, I think it was, in Nagoya. And I went to a meeting there, saw this, they wiped away all the other competition. And that was what kind of prodded me. So that plus having the money to buy a GPU server for the first time made me realize, no, we have to go to the CNN. So for the medical domain, that was what got me into it. And then for the medical domain at large, the key paper there was the UNET paper. So the mechanism for training segmentation algorithms very, very efficiently. And I'm blanking on the name, which is very embarrassing, but the chap who did the UNET to look at microscopy images originally, again, was very, very influential. So yes, the computer vision thing obviously influenced them, but at that time, then it went through the sort of interpreters of those two groups for the mitotic cells and the segmentation. And then that's what really created the deluge of medical imaging AI applications.
Full on to the hype cycle. Thank you very much. I appreciate all your time today. And for everyone that is still on, I just thank you very much. This is the end of our season. So appreciate everyone's engagement and participation throughout the season, and stay tuned for the fall. And we'll have a number of good sessions lined up for you then. Thank you very much. Have a great weekend, everyone.